And this brings me to our work in South Africa in particular. And I'm delighted to introduce you to Gqibelo Dandala, who's on screen. Hi, Gqibelo. Gqibelo, you've been with us now 6 months. I can't believe it's six
Yes.
months, but you started in August. And
Yes.
you really hit the ground running. You've spent a lot of time going up and down to the Eastern Cape. You immersed yourself during your summer holidays there for a few weeks. So I just want to ask you, what, now that you have a much deeper insight into what the issues are that we are dealing with, the role that we are playing on the ground, I'd just like to get your reflections on that and for everyone's benefit.
Thanks, David, and hi to everyone this evening. I think one of the things that struck me the most when I started at 121 and went to the project site to visit the project and to visit our clients and our team on the ground was just how rural the place was and the extent of the poverty one came across. I'm from the Eastern Cape myself. I'm familiar with rural areas. I'm familiar with with what I thought would be the type of poverty I know. But I was just struck by just how poor they were. I was shocked. I'm a South African through and through, but I was shocked that in my country, in my South Africa, the levels of poverty in 2021 were still that steep, where you would go to spaces where you just understood that, you know what, I will not be contactable because there's no network coverage. There's just so many things that we take for granted on an everyday basis that just don't exist. And it confirmed for me, first of all, that we truly at 121 are serving what we are referring to as last mile communities. Those communities that have nothing beyond them. They literally have an ocean beyond them. There's nothing else there. So that was the first thing that struck me when I started at 121. But in coming to understand the project, the Enable project, and in particular, the mentor mother model that is used at 121, I realized, and what continues to impress me every day, is that this is a model for delivering primary health care that is based on one, localization. So you use the people of that space to deliver that primary health care, first of all. The second element, which I think is also so brilliant, is just the adaptability of this primary healthcare model. And let me explain what I mean by that. At 121, our primary focus is on improving maternal and child health outcomes and development outcomes, delivered through the mentor mother model. But what I've also come to realize and continue to see is that this mentor mother model that is based on door-to-door personal relationships to deliver primary health care, it can literally be adapted to any kind of whatever the disease or the burden of illness can be in a community. So for example, in our community, HIV is a big issue, and we've addressed that. We've managed to bring down mother-to-child transmission rates virtually to 0%. But other things can be brought into it. Our team, for example, is currently being trained on how to detect diabetes very early on. We also are now able to help our clients who have TB, even though our focus was initially HIV. So just the adaptability of this model, a model which can be used virtually anywhere where there are very little resources, which is the case in our communities. But where we have a presence, there are stark differences and improvements in the health outcomes of our clients in those communities compared to villages nearby that do not have our mentor mother model being utilized there. So I think for me, that's something that's just been amazing to see and to witness. And really, I understand now the need for us to not just continue with the mentor mother model, but to really say, government, we know that you are having issues of an overburdened health system. We know that you have issues of communities that are hard to reach, that don't have clinics and hospitals nearby. Here is a model that we've tried it, we've piloted it, we've tested it, and it works. We've got the numbers, we've got the stats, it absolutely works. So that really struck me, and especially because depending on what the need is in the community, it can be adapted. So if you, for example, you go to another part of the country where the issue is fetal alcohol syndrome. It can easily be adapted. If you go to a community where diabetes is the issue, it can easily be adapted. It's the methodology that is key. It's the methodology that is genius and really delivers the primary health care.
Thank you. Gqibelo, one last thing, because you've already got to the heart of government to be able to persuade them to take this model on in different shapes and forms, because I think you've been invited to join a national steering committee. Just tell us in one sentence, what is the steering committee that you're going to be joining?
So I'm joining a steering committee that is going to be overseeing a process whereby the current community health worker strategy for the National Department of Health is being reviewed. So they're looking at the strategy, they're looking at also the training. How do they train? How do they equip? How do they prepare their community health workers? So I've been invited because of the work of one-to-one and the success of our mentor-mother model to help be in that steering committee and to help inform that process with our learnings.
Okay, so that's the holy grail for us, to get our model adopted by government, initially by the provincial government, and we've taken a number of big steps towards that. And great to have you on board, Gqibelo. I'll be traveling to South Africa next week and look forward to meeting you face to face.
Absolutely.
Right. So